the Cloud CME mobile app. This was also included in your packet for the invite, and you can also see the instructions on the PowerPoint. Secondly, please make sure that you mute your microphones. And we will use the chat function in Teams throughout the presentations for questions. At the end of Dr. Packard's presentation, I will read the questions and ask that he respond to those. Also, just to help with bandwidth, make sure that your video camera is turned off. I don't see any on right now. And to pin Dr. Packard or whomever the speaker is, just click on the right upper hand side of the presenter's name or icon and select the pin icon. So we're going to go ahead and get started, and just going to read a little bit about Dr. Packard. Dr. Matthew Packard is a board-certified radiation oncologist specializing in head and neck cancer, multi-specialty team, and stereotactic ablation radiotherapy. He holds a BA in economics from Dickinson College, completed a post-baccalaureate medical science program at the University of Pittsburgh, and holds a Doctor of Medicine from the University of Toledo, interned at the University of Pittsburgh Medical Center, Mercy Hospital in Pittsburgh, and completed his residency at the Allegheny General Hospital in Pittsburgh, where he served as chief resident in the Department of Radiation Oncology. Dr. Packard has been a radiation oncologist with Spectrum Health since 2014. Please join me in welcoming Dr. Matthew Packard to discuss complications from radiation.
Thank you. I'm just
You're
gonna
welcome.
try to get this. Okay. Is the screen shared correctly yet?
I see your screen and the first slide of your presentation.
All right, great, perfect. So as Nikki said, my name is Matthew Packard. I'm one of the radiation oncologists here at Spectrum Health. Really appreciate, excuse me, the opportunity to speak today. Yeah, and thanks to both Catherine and Nikki and the rest of the organizers for all they've done. I know it's been tough. I'm sure tougher this year, you know, with the COVID stuff and all the organization on Zoom, but everything I've heard is it's going really well. So thank you. So I'm going to talk a bit about survivorship after breast radiation. I picked this topic because breast is one of the most common indications for radiation and also has for many patients, a very good prognosis. So we have a lot of survivors. You know, as you said, one of my specialties is head and neck. Thought about doing that as well. Would love to at a different time. You know, all of the radiation disease sites have such a different course and survivorship course afterwards, from head and neck to breast to gynecologic to GI. You know, I certainly can't cover that all in 25 minutes. And also, you know, this is a very diverse audience, and giving a talk to such a diverse audience, from, you know, survivors themselves through nurses, through physicians, you know, it's tough to tailor your talk to the audience, but I did try. I hope that the scope and breadth of this, you know, is appropriate for most in attendance. So what I'm going to talk about, basically two halves of the talk. The first half, I'm going to concentrate on these three things, sort of an overview of just breast radiation, to kind of, so we're all on the same page on what we're talking about. And then short-term and long-term side effects. And then the second half of the talk will be about kind of techniques, newer technologies, treatment paradigms that can improve on some of these short and long-term risks. And then, you know, we'll have, I think, 10 minutes for questions at the end. So, you know, much of survivorship deals with the bad things about oncologic treatment. And I'm sure this will come up with Dr. Vanderwood's talk as well. You know, how bad chemotherapy can be, how bad radiation can be. But before we dive into that, it's probably helpful to at least briefly mention how beneficial some of these interventions can be. So I just wanted to go briefly over some of the more seminal publications or trials that established the efficacy of radiation in the management of breast cancer. So this was called NSABP B06, was one of the first trials to really usher in the era of breast preservation. Prior to this study, many still thought that the only curative option with regard to surgery for breast cancer was mastectomy. When the initial trials of lumpectomy alone had less than stellar results with similar results to this, upwards of 40% local recurrence rates, which were much higher than what they would have been seeing in the mastectomy treated patients. But when they added whole breast radiation, it was a dramatic reduction, 40% down to roughly 15%. And, I bring up these data with patients every week, several times a week that's why you're here. That's why you're in the office talking to me about radiating your breast after your lumpectomy. In the more advanced patients, the lymph node positive patients, there's similar dramatic improvements in mortality, upwards of 10% in this meta-analysis by adding in chest wall or breast, whichever surgery was performed, and lymph node radiation for the lymph node positive patients. And another more recent trial that adding in some regional node radiation in addition to the breast treatment also improves disease-free survival by 5%. So a lot of good comes out of why we're getting into this situation in the first place. And when a patient comes and sees us, initially there's going to be a consultation, and that's where we're going to discuss whether radiation is appropriate, if so, what type, what dose, etc. And then the next step is a simulation. And part of that simulation is establishing a treatment position. These are some typical ones that we would use for breast cancer. We'll talk about a few others later. So it's usually in the supine position, 5 to 20% incline, arms above the head. This is kind of a funny picture. Usually this arm's up here, but and then we'll we'll obtain a CT scan of the patient in that position. And from there is when we do our radiation treatment planning. So most people are probably familiar with CTs, but I just want to orient those who aren't. So these are axial slices of a CT acquired of a patient in the treatment position. So we kind of think of the patient as their feet coming towards you, head going away. And so the right-hand side of the patient is going to be on the left-hand side of your screen, and likewise the left on the right-hand side of the screen. Air is black, like in the lungs here and around the patient. Bones are these sort of calcified white, tissues, organs, etc., are kind of different shades of gray. So this is the patient's right breast, and this is how we would typically arrange our fields. One beam coming in this way, we'd call that a medial tangent, and one coming in this way, we'd call that a lateral tangent, and they're opposed. And the goal of this arrangement is to irradiate the breast tissue here. Hopefully you can all see my mouse as I'm using it as a pointer, while minimizing as much as we can the dose to the underlying tissues like the right lung and the heart. And this is showing the similar thing on a left-sided patient. We're sort of taking advantage of the fact that the breast-like extremities sort of protrude out from the body, and we don't have to point the beam through much of their viscera like we do in some of the other disease sites. Like if you can imagine if we were treating an esophageal cancer here, there's no way to sort of skim like we do in breast cancer. So that's one advantageous aspect of using radiation for this disease. If we're also treating lymph nodes, we're going to have some fields a little bit lateral, but mainly above those. They sort of match up here. We call it a match line. We outline their next echelon drainage. It's usually the surgeon's getting the lower axillary lymph nodes. They have a tough time digging up under once you get near the pectoralis minor muscle or up closer to the brachial plexus and the blood vessels up here. So that's the stuff sort of that we're going to be covering in these lymph node positive patients with radiation. As you can see here, it does add a bit, if you see here in this sagittal cut of a CAT scan. This is, rather than an axial cut up here, the axials are sort of if a patient was put into a bread slicer and sliced, and then you take one of those slices and look at it. These coronal and axials are more if you put the patient through a sawmill and sort of saw them that way and kind of look at the patient that way. But you can see that the superior or apex part of the lung, apical part of the lung, does receive a little bit more radiation if we're going after the lymph nodes. During the treatment course, I tell patients that there's usually 2 side effects that are essentially unavoidable. One is some fatigue, usually starts about halfway through the treatment course, not dramatic. Most patients will tell us that it's not as significant as their chemotherapy fatigue if they have already gone through chemotherapy, but it's real nonetheless. Most commonly what we'll hear is a patient will say, you know, Doc, I'm normally good until 10 o'clock, but the last week or so, you know, 8:30, I'm getting pretty tired, and I'm telling, you know, my husband or whatever that I'm going to go lay down, or I usually don't nap on the weekends, but, you know, last Sunday at 2 o'clock in the afternoon, I went and lay down for a little bit and I felt better afterwards. That happens very commonly during radiation. The other thing is some local irritation, inflammation of the treatment area. So it could either be breast or chest wall alone, or also the lymph node region if we're targeting that as well. It often starts out dry, itchy, a bit pink. Transitions as you get further along in the treatment course, more like a frank sunburn. Some patients are more bright red, some a little bit more of a rashy appearance, some even get some peeling. Rarely, the side effects would be significant enough for us to take a short break during radiation and give them a few days off. And then most patients recover from that. Within, you know, several weeks, 2 or 3 weeks afterwards, their energy level is back, their skin is much better, the color is starting to return to normal. And next, we're going to transition into the long-term side effects, but there's one sort of intermediate side effect possibility that I did want to touch on briefly, and that's this entity called radiation pneumonitis. This one is kind of its own unique animal with radiation. Most of our side effects are either acute or chronic, but this one's sort of subacute or intermediate phase, and it often would occur between 1 to 6 months after radiation. The key point there is it rarely, if ever, occurs during radiation. So if we have to keep in mind, if patients develop these lung symptoms during radiation, this is probably not the case. This is actually usually after radiation is completed. But the symptoms are shortness of breath, dry cough, sometimes a low-grade fever, and sort of just some chest discomfort or tightness. The severity can vary from mild cases where it's just a very self-limited cold-like syndrome to, you know, it could be very significant in some patients. The bad cases are very rare in breast. They're going to be a little bit more common in lung cancer, esophageal cancers, other ones where we're pointing, you know, a greater percentage of the beam through the lungs. Pneumonitis rates are very low. It's been reported less than 3% with standard radiation fields, even far lower than that if we're not treating lymph nodes. In my 6.5 years or so here, I maybe have had one patient or something like that with radiation pneumonitis from breast. So it's not very common. Other things can influence it. This is one of the reasons why we do the timing we do the way we do, with radiations often sandwiched between chemotherapy and before the estrogen modulation therapies, because some of those can have effects on the rate of pneumonitis as well. And whether or not a patient gets pneumonitis, there can also be some lung fibrosis. I'm going to just scroll back a couple of slides. It's often in the areas that were irradiated. So in the breast-only fields, it would be here in the front part, or if we're in the lymph node fields, could also be here in the top part of the lung. Most of the time, it's not something that patients would notice. More commonly, it would be found radiographically, where they would just, you know, get a CT scan several years in the future for whatever reason, and the report may note that there is some scarring, and the radiologist will often even point out in their reports, hey, did this patient have breast radiation? Because the radiographic appearance is very characteristic and very linear, and not a lot of other, you know, infectious causes are as linear as that. Those are more anatomic, where you'd have like a lobar pneumonia. This doesn't respect the anatomic boundaries as much as it does the field boundaries. Now transitioning into more of the, you know, long-term possibilities. One entity that gets talked about quite a bit is lymphedema, which is swelling of the ipsilateral or same side breast, hand, or arm. And that, you know, isn't only due to radiation. It's a combination of radiation and surgery. most publications suggest that surgery is the biggest predictor, and it's often the number of lymph nodes or how extensive the lymph node surgery that was performed. But radiation absolutely does play some role in this. And this is one where we have made some strides or changes recently. This is one trial I just wanted to bring up. This was a practice-changing trial when it was published a few years ago. They randomized patients who had a positive sentinel lymph node. And I know most people may or may not know what a sentinel lymph node is. It's when they sample the sort of highest yield lymph nodes at the time of breast surgery. It's the lymph nodes that are most likely to have cancer in them. And they're sort of checking those first with the expectation that if the cancer has gone anywhere, this is probably where it's gone. And prior to this study, most of the time, if it was positive, that sentinel node was positive, they subsequently proceeded on to do an axillary dissection. And then in that node positive patient, we do know that radiation was beneficial, so would further treat them with radiation. Now, what this trial has showed is that it's safe in some patients to skip that dissection part and go straight to radiation. And where that helps is primarily here with lymphedema. So I'm going to highlight these. This is the cohort that went on to axillary lymph node dissection and what their lymphedema rates were, depending on what type of radiation they had. These are breast or chest wall only, breast, chest wall plus. These are just different ways of doing lymph node radiation. But if we did the dissection, you're here in the low 20s for many of the, if we add in radiation afterwards, rates of lymphedema. If we skip the dissection here, sentinel lymph node biopsy only, we're down in the mid-single digits. So it brings them from roughly 20 to 25% down to 5% or so risk of lymphedema. So this has been a major benefit to many of our patients over the past few years. And while we're talking about lymphedema, this was just an interesting study I had come across on survivorship and sort of lymphedema prevention after treatment. This was the best study that I've seen on looking at what other factors above and beyond the oncologic treatment may predispose patients to lymphedema. And what it suggests is that cellulitis or a bacterial infection in that arm absolutely does increase the risk of lymphedema. Trauma to that arm appears to, but other things that we commonly talk about like flying or blood pressure measurements or blood draws don't typically, or at least according to this analysis, increase the risk. Blood draws I'd be hesitant about because that could be, lead to trauma if you blow a vein or something like that, or cellulitis if it gets infected. But nevertheless, some of these other things, and this is important for instance, patients who have bilateral breast cancers, they need to get their blood drawn somewhere. So that does seem to be very low risk for them. Probably the most important long-term side effect risk is with the heart. Prior to the past decade or so, we really didn't appreciate how significant the heart risk was after radiation. But this trial really was a practice-changing, or not really a trial, but a publication was really a practice-changing publication where it showed that as the mean dose of radiation to the heart went up, so did the patient's risk of a major coronary event. And that's changed a lot in our field. Nevertheless, however, radiation was still beneficial. And this is, again, similar numbers that we saw before. Any first recurrence, radiation is the arm down here. This is if you skip radiation, their recurrence way up here, almost doubled. And even overall survival, 3% improvement, 4% reduction in the death of dying from breast cancer. And this is going to take into account, when you look at overall survival, all the good things from radiation, the 4% improvements in cancer-specific survival, but also the bad things. And really this 1% difference is what we're trying to reduce now, because we essentially would be expecting the patients to be, 4% of them surviving better, because that's what we're talking about with breast cancer, but only 3% are. And when you really dive into these numbers, it really seems that heart and cardiac risk, a little bit second malignancy, but mainly cardiac risk, is the biggest risk why we're at 3% rather than 4%. So the rest of this talk is going to be, how are we going to get rid of this 1% problem, from radiation? So the simplest way to keep the heart out of the field is what we call a heart block. So this is a beam's eye view of a radiation beam. So it's kind of, this would be our medial tangent. Everything in this part of the yellow block would be in the field. So if a patient has a tumor here, this is fine. It's okay to block out the heart and miss a little bit of the breast because that's a very low risk area. But if a patient has a tumor right here, that's tougher. You know, you can't miss the tumor bed because that's, you know, really not going to give them very good local control rates. So that's where some of these other techniques come in. One of the biggest ones and also one of the simplest ones has been just changing the position we treat many of our patients in. These are prone breast boards. So rather than that supine position we showed earlier, so for patients with particularly larger or more pendulous breasts, we put them on these boards and it kind of, you prop up the contralateral breast and sort of tuck it out of the way and they sort of lay on that. And then there's a hole in the board for the treated breast to fall down. And it can bring the breast and the tumor bed just further away from those riskier areas like the rib, the lung, and the heart. And this is a picture of one of our patients. This patient was treated out in Holland, but of a supine scan and a prone scan. So this is a tumor bed here. And if you want to treat the whole, I'll kind of outline the breast tissue here. So if you wanted to put a standard tangent on that and cover all of this breast tissue, you're going to nick the heart a little bit. So you could do something like this and just treat over here, but you're missing this breast over here, or something like this, but then you're missing the breast over here. But if you flip that same patient over and have that breast just fall away from the heart, you can do a beams out here where everything in front of it is covered. You also minimize the rib in the field. There's essentially no lung in the field and no heart in the field. And I'm going to show another similar picture kind of just with the structures highlighted. Again, on the left is supine. On the right is prone. The heart is shown here in this greenish teal. Lung in orange, tumor bed in red. So this box, again, is demonstrating where the radiation field would be. So this is showing that you're getting a little bit of heart and a fair amount of lung to cover this breast and tumor bed adequately. You flip that patient prone, that breast and tumor bed move forward, you change the angle of your beam a bit, and you have really no lung, no heart, and actually better coverage of the breast and tumor bed as well. So we do this a ton recently. Again, just to summarize, prone, less heart dose, less lung dose, better coverage, better dosimetry. It can be a little bit uncomfortable for some patients. And in the radiation world, laying on your back is the most reproducible for us to get the patient in the same position every day. We can account for that, though, with imaging and other things, too. In the interest of time, I'm going to skip this one. This is a sort of a poor man's prone. If we can't do that, then we have some like corset type things that we can use to get a similar effect, but I'll skip that. This is one I wanted to spend a little bit of time on. This is sort of our latest and greatest thing here, what we're doing for breast cancer. It's really exploiting the anatomy. And on the left-hand side here, we're showing a patient at full exhalation. And on the right, we're showing a patient at full inhalation. Our anatomy is such that just in front of the heart, but behind the chest wall and breast is a little sliver of lung. But when we're at full exhale, that lung is pretty much collapsed and the heart, as shown in this picture, gets very close to the chest wall. But when we're at full inhale, that lung expands, actually pushes the heart and mediastinum back and moves the chest wall forward a bit. And if we can treat the patients while they're holding their breath, we can sneak that beam through there without hitting the heart. And how we accomplish that, there are several ways. One of the ways we use is we have the patients breathe through essentially a spirometer, give them like gaming goggles to watch or to wear, excuse me. That's going to show their breathing. And it shows them inhale, exhale, inhale, exhale. And then our staff, some of which I think are on the call here, will tell them, all right, whenever you're ready, take a big deep breath. And then they take it all the way up here until it gets into this green and then they hold it. And then the machine comes on and they treat until they basically can't hold it anymore. And then you kind of just repeat that process. Data suggests about a 50% reduction in heart dose by doing this technique. This technique is great because contrary to prone, we can use this for mastectomy patients. We can use this for lymph node patients. So it really opens up a lot of possibilities for us to reduce the heart dose. A few other things on the other technologies. Partial breast radiation there's some data suggesting that in many patients, the whole breast doesn't actually need to be treated. And we essentially just treat the area around the lumpectomy bed. You know, a small subset of patients are candidates for this, but those that are, this is also a very good way of reducing the dose to, you know, all the structures, the ribs, the heart, and the lung. And the best way of reducing radiation side effects is not to do radiation at all. So this is a study that was published that I bring up again a couple of times a week, that shows that in certain well-selected, very low-risk patients following lumpectomy, it may be safe to even omit post-operative radiation. And how they defined ultra-low risk in this trial was everyone had to be 70 or older, small tumor, and that was defined as 2 centimeters, estrogen receptor positive, had to agree to 5 years of endocrine therapy, and had to be completely excised. And then they randomized those patients. They basically repeated that old NSABP B06 study. Half got radiation, half didn't. But what they found was that in this modern low-risk population, it wasn't 40% and 15% anymore in the no radiation and radiation arms. It's 10 and 2. So that's, you know, a much better option, 10% for if you skip radiation versus 2% if you do the radiation. How this typically works out when we present it to patients who meet those criteria, if they're in their early 70s, in good health, with transportation and things, they still usually opt for the radiation. But for patients who are a little bit older, in poorer health, or you know, have caregiver responsibilities at home, you know, 10% is not a bad risk. So we present this data just like this to patients all the time. And the nice thing about that is if we don't do the radiation at all, they don't have any of these side effects. So that's all I have. I'm really hopeful that people have some questions.
Thank you very much, Matt.
AJ, did you have a question?
Yes, I do. I always have questions, especially for a great talk like this one. Can you just comment on the last trial you mentioned? This was with tamoxifen, though. Would you speculate if this was aromatase inhibitor? Would you speculate that the 90% would have been a little better?
You're right. It may have been. Yeah, this was definitely a tamoxifen trial. And I even mentioned that to patients that since this trial was done, technologies are better. You know, with this trial was pre-breast MRI, pre some of the pathologic techniques that we have now for picking up, better margin analysis. Surgical techniques are a little better. Some of the radiation techniques are even, so it may even be a little bit better than that in some of these patients.
Thank you. And back to the lymphedema, is it really I agree with you, we have so many old information, and we go by habits, right? So nobody would reconsider the blood draw, for instance. But would you feel one way or the other strong, any strength in your heart about the blood draws from the arm of the side of, and hopefully Amy can comment on her talk.
Yeah, my gut would tell me avoid blood draws if you can. And that study is kind of funny. So if you have a blood draw, and it wasn't a study, but it was sort of a meta-analysis, but if you have a blood draw and it goes great, it seems fine. But if that blood draw happens to lead to some sort of trauma, then it's not as good. Or if that blood draw happens to lead to cellulitis, then it's not as good. So it does probably seem to be prudent to avoid them if at all possible. Probably the bigger two things about there was it's perfectly safe to fly, and blood pressure measurements seem perfectly safe too. We get asked that a lot. It's not as uncommon as people think for us to have either synchronous bilateral cancers or metachronous bilateral cancers, and they often ask us that, like, hey, I've been told my whole life I can't get my blood pressure drawn after my right-sided cancer. Now you're treating me for a left-sided cancer. What am I going to do? And we, I'll pull up that data and say, I'm no expert myself, but it seems to be that you're going to be okay.
Mm-hmm. Thank you.
Dr. Packard, Mary Kay has a question for you. She recently spoke with a patient who traveled to MD Anderson for care, and this patient is a runner. The Sharpie did not help with keeping her marks on her for radiation therapy, and the team at MD Anderson used henna. Curious if we offer henna as an option instead of the tattoos.
I haven't used henna. We either our two options usually are the tattoos, or we can do we'll do the Sharpies with stickers over them. It probably wouldn't help as much for running because you're perspiring. Where they really help is showering and those sorts of things. But yeah, it's something we could look into. That's very interesting. I haven't used that at all.
I think that's something that myself and the other directors, I can touch base with Alyssa. We can take that offline. I believe, Ellen, you have your hand raised. Did you have a question for Dr. Packard? I'll head back over to the questions. I just had noticed that a hand was raised. So you mentioned skin irritation being a side effect. What do you recommend for at-home treatments to help with this?
That's a great question. And that's one that is not a one-size-fits-all approach. So our nurses are seeing the patients for a very in-depth teaching session at the beginning of radiation, and they're going over all that. And one of the things they say is that, it's not the same for all patients. We're also seeing them every week, a nurse and a physician seeing them, where we're looking at their skin and giving them, detailed recommendations on, what to put on, also what maybe not to put on. There are, we for instance, we don't like things caked on the skin right before radiation, because that actually, it's complicated, the physics of it, but it actually makes the radiation side effects worse. In general, we tend to rely on mostly over-the-counter stuff, moisturizers. Aquaphor is one we use quite a bit. Aloe is another one we use a lot, as well as anti-itch remedies like hydrocortisone, and then some topical numbing ones. One that we use a ton, and over-the-counter one is Aspercreme with lidocaine. And there are a bunch of other things, Dombro soaks, some astringents, some other, where we're giving them different sort of gauze-like bandage things to keep skin off. And so there are some more tailored interventions, but those are kind of in general. But I guess the point of all that is, when you're under treatment, that's when we're going to be giving you your personalized, detailed recommendations on what to use and what not to use.
Thank you. Any other questions or comments? Catherine,
Hi, this is Catherine. You had maybe touched on the second cancers. Can you kind of expand on the importance of surveillance for these?
Yeah, that's a great question. So second malignancies is a big topic, and it's really a talk, unto itself in radiation. And it's dramatically different on a lot of different things. Where are we treating? What's the prognosis from the cancer we're treating them for? What's the patient's age? We have a dramatically different conversation with the parents of a 5-year-old than we're going to have with an 85-year-old breast cancer patient. With regard to breast cancer specifically, most of what's talked about is actually the risk of breast cancer from other radiation. Mm-hmm. Okay, the classic one is, like Hodgkin's lymphoma. The older treatment fields in the pre-effective chemotherapy era were giant fields treating their whole neck, their armpits, their mediastinum down into their abdomen, spleen, groins. Those fields absolutely place patients at higher risk for breast cancers, and they are screened differently. They're screened similar to like the patients who are high risk from a genetic perspective. The other side of that coin is, well, what about patients who were just treated for breast cancer? So the one nice thing is that it's a more localized field, less viscera exposed to radiation, but without a doubt, there are higher rates of cancers in those areas. I did drop that slide at the last minute just because when I practice at home, I was running over. So it basically, it's about a 25 to 30% increase versus the general population of any cancer. They typically are cancers in that area. The classic one is a soft tissue sarcoma, but also can be lung cancer or esophageal cancer. Interestingly, if you look at patients who have the same breast cancer but don't get radiation, they're also at higher risk of additional cancers and they don't know exactly why. Probably it's about an 8 to 10% risk. So radiation does take that up another step. They're thinking that even the patients who don't get radiation, sort of the crux of it is the fact that they had one cancer means they have something going on genetically to sort of predispose them to that, and they remain at higher risk versus the general population subsequently as well.
I'm curious, Dr. Packard, for those patients that are very high risk, is there a communication process or education or a relationship collaboration with the primary care physician for an increased awareness regarding that patient's risk?
Yeah, absolutely. There should be. Yeah. And this, is a collaboration with us and Dr. Vanderwood's group. I mean, they have the most robust survivorship counseling. Most of the patients consolidate their follow-up there, but yeah, we absolutely try to communicate that, to whoever's going to be caring for them, whether it's, someone from Dr. Vanderwood's group or their nurse practitioners or their primary care, to make sure they're getting plugged into the right, hey, are you twice a year? Are you breast MRI? Are you whatever? And again, most of those are patients not treated for breast cancer initially. Those ones are just, we're kind of following the NCCN, surveillance guidelines, but it's the ones who were treated at earlier age for, lymphomas or, something, even keloids and things over the breast, which we try as hard as we can not to treat with radiation, but it comes up now and then.
Right. Thank you. Andrew has a question for you. Can you explain when you use a bolus for breast patients and why that causes differing side effects? Her aunt had some pretty significant burns from her radiation and was under the impression it was from the bolus.
Great question. Yeah. So we're going to get a little technical, and our radiation therapists are probably giggling, the ones who are on here now. But so bolus, the use of the term is completely different in radiation than it is in the rest of medicine. In the rest of medicine, you think of a bolus dose of a medication. What bolus means in radiation is a substance placed on the skin surface to increase the dose to the surface of the skin. And the way it sort of works, when a photon radiation beam interacts with tissue, those photons have to be converted to electrons, and then those electrons interact with the tissue. And it's mainly water, and specifically the oxygen molecule in water, or the oxygen atom. And they create these oxygen-free radicals that interact with DNA. And we're hoping to affect a double-stranded DNA break in the cancer cells so that they are non-viable. When that beam is hitting the tissues and going through that process, the first couple of millimeters actually don't get a lot of those oxygen-free radicals. It's kind of just a physics thing that the beam is forward pointed and it pushes that energy deeper. We use that to our advantage a lot of times because we actually don't want dose in the skin. For instance, a prostate patient, esophageal patient, we don't want their skin dose. We want that dose deeper. But in many breast patients, not all of them, particularly post-mastectomy, the most common site of recurrence is actually in the skin of the chest wall. So we don't want to miss the skin. So we do place on the skin this substance that's a similar density to tissue, to skin, electron density or water density, that when the beam hits that, we're sort of tricking the beam, and it goes through this process of developing that oxygen-free radical thing so that by the time it gets to the skin surface, it actually is at full dose. So it's a catch-22. We need to dose the skin, and the two most common times we're using it are skin cancers or chest wall breast cancers. It definitely increases the dose, but that's intentional. And we keep a close eye on that during their treatment to make sure it doesn't go too far. So many patients, it's probably 50 to 70% or something like that. We actually discontinue the bolus before the end of their treatment course, and they'll get 17 treatments with the bolus and then another 8 or so without.
Thank you. Ellen, I'm going to come back to your question because Laurel's is related to this very topic regarding the bolus. So Laura was curious what patients can do before or after radiation to minimize the effects of the bolus. Is there anything?
Really, no. I mean, the point of the bolus is to push the dose to the skin. So again, this is going to be a little bit complicated. The most commonly accepted mechanism for what we're describing as radiation dermatitis is that it's a slowdown or temporary stoppage of the skin replenishment process. So our skin cells are constantly being replenish. So like, we get sunburn or suntan and we're dark on the outside, then that eventually fades with lighter skin. Radiation essentially slows down or stops that process of the deeper skin cells migrating up to the surface. It's not really a burn per se. So our kind of goal is it's almost impossible to make that skin actually grow back during radiation because those skin cells are feeling that effect on their DNA and they're just not going to divide while they're feeling the radiation. So our efforts concentrate instead on keeping what's already there. And that's why we're telling patients, to avoid running if they can, so they're not rubbing their lateral breast on their arm, or, avoiding some tighter fitting bras that might rub off skin, or if they get itching from treatment, we're going to have them use the hydrocortisone rather than scratch it and take off some of that skin. And that's why we're having them put on the moisturizers and other things to keep that skin, those skin cells that are there as long as we can, and don't have them slough off, and don't go in, chlorinated pools, or don't be sunbathing and other things during radiation. Let radiation be the only thing irritating this as best we can during your treatment course. Within a week or so afterwards, we start to see little islands, we call them, of skin cells forming in the irradiated skin, and then they sort of fill in out from there.
That was very helpful. Thank you. Ellen has a question. How do survival rates compare with the sentinel node biopsy versus the less invasive node dissection? You had mentioned the less invasive node dissection improves lymphedema.
Yeah, it's a great question. So that trial, the Z11 trial, was very conclusive that survival was exactly the same as our nodal failure rates. Nodal failure rates were about 1% in each arm, and the arms being completion dissection. So everybody had a positive sentinel node or two, and then half of them completed the dissection and then went on to further treatment, radiation, chemo, estrogen, whatever was appropriate for them. The other half skipped the dissection, went right on to radiation, chemo, whatever else was appropriate for them. So their outcomes oncologically were exactly the same with regards to local recurrence or local regional recurrence and survival. The only difference between the groups really that was shown in that trial was that the rates of lymphedema were dramatically lower in the cohort in which we skipped the dissection. And again, not all patients are candidates for that. That trial, like all trials, has certain inclusion criteria, and it's not uncommon for us. Like I just had a conversation with Dr. Jeffers. We had a very complicated patient, another one with Dr. Hopp recently, where patients kind of almost meet those criteria, but not exactly. And do we skip it or do we not? And it's, a very nuanced discussion. But, our team here